There is one question through the chat. Please go ahead and send yours. Please send them through the app so that we can address them. The one question that's coming through so far is, are you doing MRD in any patients with amyloid? At what time points, and how do the results drive therapy decisions? So we'll let you both give short answers to that one.
Yeah. From my side, I think Angela should go ahead because I think that plays a role in newly diagnosed, less role in relapse. Angela, please go ahead.
Sure, thanks. So in terms of MRD, currently we are doing MRD testing using high resolution flow cytometry at the time that we do bone marrows, most often after transplant, and then for the purposes of clinical trials. In terms of it directing therapy at this juncture, it's really not. It's informative, but as long as a patient is actually having gradual organ response, we don't do anything with it. The data so far in terms of MRD is that it does predict for progression-free survival, but so far there's no signal for overall survival in any of a dozen reports. So again, those are all retrospective and so forth. So at the time that it may affect how we treat a patient is if they're doing well, they're MRD, they're having now all of a sudden organ progression, there's no monoclonal protein, there's no free light chain, do a bone marrow, and if you see something there, then it kind of gives you the imperative to think about giving plasma cell directed therapy.
Yeah. I mean, I completely agree. Quick answer from my side. I do it when patients are in CR. I think we collect the data. It helps me a little bit to make a decision on transplant. So if patients are MRD negative in a CR, usually our transplanters are not in favor of proceeding with a transplant.
Agree. That's a really hard one, and I think we're in a place of a data-free zone in terms of what to do, because we don't know. The Andromeda trial, fantastic responses, but we don't know how durable these things will be, and we don't have tons of MRD data yet on that particular or that particular study in amyloid. So more to follow.
Yeah. I think we are running out of time, and I get the signal here that we have to proceed with our next presentation. Angela, thank you so much. As kind of, my hero in amyloidosis, it's always a pleasure to hear to you.
Thank you.
But it's also a pleasure to introduce the next speaker because this is Professor Amrita Krishnan, our superstar from the West Coast. Amrita is here. She is at City of Hope National Medical Center, Duarte, California, in the USA. I would say she's very dedicated to transplant and amyloidosis, and she will talk about frontline therapy in transplant-eligible, newly diagnosed multiple myeloma patients, pros and cons, quadruplets, early transplant, or just Revlimid for maintenance. Amrita, please go ahead.
Thank you to the organizers for the opportunity to present on frontline therapy for newly diagnosed myeloma, the role of stem cell transplantation and maintenance therapy in 2021. My name is Amrita Krishnan. I'm the director of the Judy and Bernard Briskin Center for Myeloma at the City of Hope Comprehensive Cancer Center. So for many people, transplant in myeloma is sort of like your Volvo. It's reliable, it's safe, it gets you where you want to go, but it's not particularly exciting. So people continue to try and look to the future, look to the Teslas of myeloma, new therapies, more exciting options as well. But ultimately, really, we still need to get from point A to point B. So how do we make transplant better? Well, one of the things I'm going to talk about is maintenance therapy options using newer agents, as well as also thinking about duration of maintenance therapy. The other biggest change that we've seen moving forward is our goals of therapy. And what I mean by that is try to get deeper and deeper responses for patients because we know that that translates into longer survival. We want to improve quality of life for patients, and ultimately our future goal is cure. So first of all, let's look at our goal of deeper responses. And really the goal in 2021 is getting patients to become MRD negative. And this is data from the Spanish groups suggesting that MRD is really what is driving progression-free survival. And in fact, if you have a complete remission, but you're still MRD positive, you're no better than a patient who's in a partial response. Now, let's talk about our vulva or stem cell transplantation. Many of you are familiar with the IFM trial, which looked at what was therapy when this trial was opened, RVD chemotherapy for induction. Both arms had stem cells collected. One arm had traditional high-dose melphalan, followed by 2 more cycles of RVD and 1 year of lenalidomide maintenance. The other arm had a total of 8 cycles of RVD and 1 year of len maintenance. You're very familiar with this result that was published in the New England Journal, showing a better progression-free survival for the transplant arm, but 4-year survival was similar in both arms at around 81%. This trial has been updated now with 8 years of follow-up, and the progression-free survival benefit remains for the stem cell transplant arm, but we still do not see a significantly different overall survival benefit to transplant, but notable that 80% of the patients in the RVD arm at time of relapse did undergo stem cell transplantation. But getting back to our theme of MRD, I think an important point to notice is this. First of all, more patients in the transplant arm became MRD negative, and you can see, interestingly, the curves, while not statistically significant, certainly the patients who had an MRD negative after transplant separated from those who were MRD negative after RVD. Another point I should mention, and this is important when you talk to patients in the context of should they undergo transplant or not, is MRD in the non-transplant arm in this trial was measured after 8 cycles of RVD. But when patients come to talk to us about proceeding to transplant or not, many of those patients have only had 4 cycles of RVD, so it's somewhat of a different paradigm. Now, of course, we look to the future, and the future is a more intensive induction, and one of the options is the addition of monoclonal antibodies. And the first approval was for Cassiopeia. DARA plus VTD compared to VTD alone as an induction. Both arms underwent stem cell transplantation. One arm continued with DARA VTD consolidation, the other with VTD consolidation, followed by a maintenance, which I will discuss later. Getting back to our theme again of depth of response, you can see with the addition of the daratumumab, we had a greater depth of response, including MRD negative rates in the DARA arm. Also notable when you talk about MRD, you need to look at how it was measured. In this case, it was measured by flow cytometry at a sensitivity of 10 to the minus 5. We also saw a progression-free survival advantage to the DARA arm compared to the observation arm. This is now the maintenance portion. But of course, in the United States, we tend not to use VTD as our standard induction. And thinking back to the IFM trial, certainly RVD still remains a very common induction. So how do we improve upon RVD? The Griffin trial was a randomized phase 2 trial. Important to note the endpoint was stringent CR. Patients were randomized to DARA RVD or RVD. Both arms underwent transplant, followed by consolidation. One arm had DARA lenalidomide maintenance with the DARA stopped at 32 cycles and len continued. The other arm was straight len maintenance. And as I said, the endpoint being stringent CR. Again, our theme of MRD, you can see that the response rate was higher in the DARA arm, and the MRD rate was higher in the DARA arm, approaching 51% of patients becoming MRD negative at the last follow-up in the DARA arm, compared to 20% in the RVD arm. So again, suggesting intensive induction with the transplant strategy, followed by maintenance, can achieve at least 50% of our patients becoming MRD negative, which is really now more and more becoming our goal. Now, if you don't want to use a quadruplet, what are your other options? One is to intensify your triplet regimen, and in this case, we have the Forte trial using carfilzomib, lenalidomide, dexamethasone. And this trial, to my mind, cements the importance of stem cell transplantation, again, in achieving our goal of depth of response. One arm received KRD for 12 cycles, one arm received 4 cycles of KRD, followed by transplant, followed by another 4 cycles of KRD consolidation. And then there was a second randomization, which I won't discuss right now, followed of KR versus R as maintenance. And you can see here that in the transplant arm, more patients became MRD negative, and perhaps even more importantly, in our high-risk patients, those with RISS stage 2 and stage 3, 90% of these patients at 1 year were MRD negative. And so certainly it's becoming MRD negative and sustaining MRD negative is important for our patients, especially these high-risk patients. And then let's look to our future, sort of our SpaceX of myeloma, and that certainly is CAR T-cell therapy. And how is that going to fit into our paradigm of induction therapy? Well, this is the KarMMa-4 trial, which is newly diagnosed patients who had defined high risk at diagnosis. And you can see here the definitions of high risk based on cytogenetic criteria. Patients who are allowed triplet or quadruplet induction, again, reflecting the current state of therapy. Patients get 3 cycles, then leukapheresis, followed by a 4th cycle of therapy while cells are being manufactured. Also important to note that stem cell harvesting is also recommended. So we're trying to keep all options open for these patients. And then patients will have a traditional lymphodepletion regimen followed by CAR T-cell infusion. Now let's switch gears a little bit and talk. We've talked about how induction can strengthen transplant. Now let's look at maintenance. And this was presented at EHA by Bruno Piver, and it looked at exacerbate maintenance. And the important point here really is, again, building on this theme of MRD, that you can see if patients who were persistently MRD positive post-transplant, regardless of whether they were on exacerbate or placebo, had the poorest outcomes with a median progression-free survival of about 14.1 months. The patients who were MRD positive and converted to MRD negative did quite well, and certainly exacerbate helped upgrade responses in a percentage of these patients. So you can see here that the 2 issues: 1, becoming MRD negative; number 2, maintenance can also help you become MRD negative. And it's important that sustaining MRD negative also leads to prolonged progression-free survival. Certainly, right now, our tried and true maintenance is lenalidomide, and I don't need to spend a lot of time on this because everyone is familiar with the data. There were several trials looking at lenalidomide maintenance compared to placebo, and on a meta-analysis, we saw that overall survival was improved with lenalidomide compared to placebo, with a median improvement of overall survival of about 2.5 years. The majority of these trials use lenalidomide until disease progression, and that remains a question for us moving forward to 2021. So now we've talked about exacerbate as a maintenance strategy. We've talked about the tried and true lenalidomide. What about daratumumab as a maintenance strategy? So this is the further update of the Cassiopeia trial that was presented by Philippe Moreau at ASCO this year. One arm received dara monotherapy every 2 weeks for 2 years. 8 weeks for 2 years. The other arm was randomized to observation. As I mentioned earlier, there was a progression-free survival benefit for the dara arm. Again, our theme of depth of response, greater depth of response in the dara maintenance arm, including something you've heard again and again now, a higher rate of MRD negativity in the dara maintenance arm. But an interesting subgroup analysis suggested that the biggest benefit of the daratumumab maintenance was in patients who did not receive daratumumab as part of their induction. Now, of course, we need more details of this, and it might be that, in fact, the patients who received daratumumab as part of their induction had already become MRD negative, so that they derived their greatest benefit from the induction portion of the regimen. Also, as I mentioned earlier, the daratumumab in this trial was given at a non-traditional schedule of every 8 weeks, and perhaps we need a more intensified dara maintenance strategy. But nonetheless, it sets the stage that, again, MRD is important. Number 2, intensity of induction or of maintenance, perhaps both, is also important. Now, the other question becomes, as we move forward for our patients, do they need to be on maintenance indefinitely? And how can we use MRD to help guide those decisions? So we have here the Perseus trial, building upon the trials you've seen earlier. In this case, DARA RBD compared to RBD induction, transplant consolidation. But let's focus on the maintenance portion here. And you can see there's a randomization. One arm gets lenalidomide maintenance, the other arm gets dara-len maintenance, and then MRD is assessed. If patients are MRD positive, they continue dara-len. But if patients are MRD negative, the dara is discontinued and they just continue lenalidomide until progression. Primary endpoint is progression-free survival. So this asks the question, if you get a deep response, can you start to de-escalate the intensity of your therapy? And then the stamina trial, and admittedly I'm biased, but I think this is probably the most important trial because the primary endpoint is overall survival. And at the end of the day, that is really the question we want to know. This trial really tries to reflect U.S. practices in that patients can have any induction they want. It allows patients up to age 75 to be enrolled, and patients can be enrolled before or after their transplant. Patients are randomized to lenalidomide or len-dara maintenance, and they continue on that for 24 months and then have an MRD assessment. At that time point, if patients are MRD positive, they continue on their assigned maintenance arm. But if patients are MRD negative, they're randomized to either continuing or discontinuing their maintenance on both arms. So this will really ask the question, probably in the most important fashion for us now, if you get a deep response, can you stop maintenance therapy? So I think this will also have a tremendous benefit in regards to patients' quality of life, and that will be one of the things that we're measuring as well. So in sum, transplant or Volvo remains a mainstay of myeloma therapy. But we're continuing to look to the future and how do we make it better in terms of intensifying induction to get deeper and deeper responses, and being smart about maintenance strategies, both in terms of intensifying maintenance, but also considering that perhaps we don't need to continue maintenance indefinitely. As we get these deeper and intense induction regimens, certainly there are patients who get deep responses early who may elect to defer transplant, and that is certainly an ongoing discussion. And certainly some of that is dependent on lifestyle, convenience, admittedly a quality of life decrement during the early transplant period. Potential second malignancy questions also remain. But for patients who elect to defer transplant, certainly it's important to recognize that the transplant still provides us the longest first remission. It's an effective, safe strategy. And if they defer transplant till relapse, if the patients are older, perhaps have developed more comorbidities, perhaps have disease that is more biologically active and difficult to control. So really our best chance to get our deepest response with an MRD negative CR is at that first induction consolidation strategy. So thank you for your time.
Dr. Krishnan, thank you so much for that comprehensive overview and coverage on many, many topics. We are very limited with our time, but we have one question which I think is very important. What is your current perspective on maintenance therapy in high-risk patients? Have there been any changes based on recent data? Maybe Amrita, go ahead. How do you handle that? High-risk patients.
Thank you, Suzanne. So very quickly, I think the recent data, certainly from the Forte trial, is intriguing, and that was just updated again, suggesting that that combination of carfilzomib plus lenalidomide is a good regimen in high-risk disease, except perhaps for the 1Q amplification subgroups. So I think that's one option. I think the use of monoclonal antibodies as part of a combination maintenance strategy is also another option for high-risk patients. And, I think certainly not just because Sagar Loniel's on the call, but his Emory data of RBD maintenance in high-risk patients is also, I think really setting another standard for many of us.
Perfect. Thank you so much. And again, I mentioned we are really short on time. I want to remind you that you can directly contact the speakers via your app and can really questions that are not addressed, really discuss it directly with the speaker. And it's my real pleasure to introduce Dr. Mariví Mateos from the University Hospital of Salamanca in Spain. She will talk about sequencing treatment for early relapse, which triplets and when. So, Dr. Mateos.
Hello to everyone, and thank you very much for the kind invitation to participate once more again in this SOHO meeting. And I will address what is the optimal sequencing of treatment for early relapse and refractory myeloma patients, which triplets and when to utilize them. Here you can see my conflict of interest. And I would like to start saying that undetectable measurable residual disease is an important prognostic factor predicting outcome in myeloma in general, and this is also applicable to the relapsed and refractory patients. And indeed, we can to optimize the minimal residual disease evaluation throughout the increase in the sensitivity level, because if we move to 10 to the -6, we are going to detect less patients in MRD negative, but its prognostic value is going to be stronger, and we have to move to evaluate what we call sustained minimal residual disease negativity over time. These new response criteria were collected by the International Myeloma Working Group, and I would like to share this slide because these new response criteria are applicable to all patients, including relapsed and refractory myeloma. This slide represents the first line of therapy according to the European guidelines published in 2017, just to put in context how approximately 2/3 of our newly diagnosed myeloma patients were treated with a lenalidomide-based combination, and lenalidomide was given as continuous therapy. And when we go to the most recent guidelines published in 2021, the situation is quite comparable, and this means that the majority of patients will receive lenalidomide as part of the first line of therapy, will progress while they are receiving lenalidomide, and in principle, these patients would qualify as lenalidomide refractory patients. If we go to our old guidelines, the recommended combinations for these patients would be either carfilzomib and dexamethasone or daratumumab, bortezomib and dexamethasone. But honestly, these combinations resulted in poor median progression-free survival for the LEN refractory population. And indeed, if we focus on early relapses, patients treated in the first line of therapy with lenalidomide and rescued with either Dara-VD or KD, these patients were not represented in these clinical studies. And this is the reason why we need definitely new combinations for this population. And from my personal point of view, the first question we have to ask us is the patient naive for anti-CD38 monoclonal antibodies? And if the answer is yes, I think that one of our first choices would be to select a CD38-based combination. Carfilzomib, dexamethasone, and daratumumab resulted in a new standard of care for this population because the Candor study showed how this combination was superior in terms of progression-free survival in comparison with KD alone. and the median progression-free survival is of approximately 29 months, but it is very important to see how this efficacy was sustained across the different subgroup of patients, including the lane refractory population and even the lane refractory after the first line of therapy. The phase 3 KEMA study reproduced more or less the same efficacy data, but in this case, the monoclonal antibody anti-CD38 was isatuximab instead of daratumumab. Isatuximab KD resulted into a significant benefit in terms of progression-free survival in comparison with KD alone. The hazard ratio was 0.53, and the median PFS has not been reached yet, and we can potentially expect even a longer median PFS than that reported in the Candor study. Almost 40% of the patients achieved complete response, and 1/3 of the patients treated with this combination achieved minimal residual disease negative. Again, the superiority was also sustained even in the lane refractory population. And this is the last study in order to confirm the benefit of this combination, KD plus anti-CD38 monoclonal antibody, in this case plus daratumumab, in the lane refractory population. This is a phase 1/2 clinical study consistent with a median progression-free survival of approximately 26 months in the lane refractory population. Another possibility is to combine daratumumab with pomalidomide and dexamethasone. This combination was evaluated in the phase 3 Apollo study, and again, dara-PD is superior to PD alone. It's true that the median PFS was 12.4 months and numerically is inferior to that reported with the dara-KD, but in this study, basically patients were included after at least 2 prior lines of therapy. This is the reason why I would like to show you here this phase 2 clinical study conducted also with POMDEX plus daratumumab, but in 112 relapsed and refractory myeloma patients after 1 or 2 prior lines of therapy, and all patients were lane refractory. So the population of lane refractory after just 1 prior line of therapy is more represented in this study, and when we evaluated the efficacy, the overall response rate is of approximately 80%, but important to look at the progression-free survival. The median has not been reached yet, but it is expected to be around 26 months, again in the lane refractory population. How to select between KD or POMDEX plus anti-CD38 monoclonal antibodies? I think that the duration of the previous therapy with lenalidomide can potentially influence in our selection. Early relapses, maybe it's better to switch drug class and to go to carfilzomib. Late relapses, carfilzomib or pomalidomide-based combinations. The comorbidities, cardiovascular diseases, we have to go to pomalidomide and dexamethasone. Prior history of second primary malignancies, maybe we can select the carfilzomib-based combination. And we have also to incorporate the lifestyle of the patient, the social support, because you know that carfilzomib requires IV administration every week. It is also possible to select for these patients combinations free for anti-CD38 monoclonal antibodies. And this is the case for the combination PVD evaluated in the Optimis trial, in which PVD was superior to VD. And important to note how in this study, all patients were LEN exposed, 70% were LEN refractory, and 120 patients were refractory to LEN as part of the first line of therapy. And in this population, the median PFS was 1.5 years. This is a possible combination, as well as selinexor in combination with bortezomib and dexamethasone, evaluated in this phase 3 Boston study in comparison with VD. Selinexor VD was also superior with a median PFS of approximately 14 months versus 9.5 months with bortezomib and dexamethasone. Superiority observed across the different subgroup of patients. I would like to remark the benefit of this combination in patients with some high-risk cytogenetic abnormalities like deletion 17p, and the superiority was also observed in patients previously exposed to lenalidomide, as well as to patients previously exposed to proteasome inhibitors. Finally, another possible combination would be venetoclax in combination with bortezomib and dexamethasone, evaluated in the Bellini study, although it's true that this combination was superior in venetoclax VD in terms of progression-free survival, but this is not the case for overall survival. We have to focus on patients with 11-14 translocation in order to see the sustained benefit in PFS without the deleterious effect in overall survival. However, the sample size including patients with 11-14 translocation was rather small, and in principle, in order to select these CD38 monoclonal antibodies naive combinations, personally, I consider that these combinations will be selected for patients previously exposed to anti-CD38 monoclonal antibodies, although it's true that there is not any evidence base because these patients were not included in these clinical studies. PVD, from my point of view, is the most solid combination for the late refractory patients. Selinexor, bortezomib, and dexamethasone is promising and it can be utilized. And concerning venetoclax, my recommendation would be to include patients in clinical studies before the use of venetoclax in combination with VD as off-label. With this information, and finally, if we review the treatment overview for patients with multiple myeloma, we can see how majority of our patients between the first and the second line of therapy will be exposed to proteasome inhibitors, IMiDs, and anti-CD38 monoclonal antibodies. And we know that there are many new agents that are being evaluated today at the late advanced stage of the disease, but its role is to move earlier on. And this is the case for BCMA CAR T cells, and we have a preliminary cohort of patients in relapsed and refractory situation after 1 to 3 prior lines of therapy treated with cilta-cel, and the efficacy results are very promising with an overall response rate of 95% and a complete response rate 75%. We needed to wait longer follow-up in order to see the durability of the response, as well as to evaluate very well the safety profile. But personally, I consider that this is the future. And indeed, in this slide, you can see how there are at least a couple of clinical trials with either ide-cel or cilta-cel conducted in relapsed and refractory myeloma patients after 1, 3, or 2, 4 prior lines of therapy. And in the future, I consider that most of our patients will be treated with PI, IMiDs, and anti-CD38 as part of the first line of therapy. And definitely the BCMA targeted therapy is going to move to early relapses. And this would be the case for CAR T cells. Belantamab mafodotin will be maybe combined with the different standard of care, and concerning the bispecific monoclonal antibodies, they will be also utilized maybe in earlier lines of therapy as single agent or in combination with immunomodulatory drugs or with other monoclonal antibodies. And I stop here. Thank you very much for your attention.
Thank you very much, Dr. Mateos. And we have time just for one quick question. So I'm going to give it to you here so that you can have as much time to answer it as you can. Would you treat a patient with a CD38 containing regimen, either ISA or DARA, if they've been previously exposed to DARA in the frontline setting? If so, would you require a DARA treatment-free interval? And if so, for how long?
In principle, I would say that there is not much more evidence about the retreatment with anti-CD38 monoclonal antibodies. We have to consider that the target is present in the plasma cells, and most patients at the moment of the relapse continue expressing CD38, but we have to consider also the immune system, because we know that sometimes one of the mechanisms of resistance is the exhaustion of the immune system. So my recommendation would be to give another line in between, and maybe after something in between, especially if the drug is enhancing the immune system, it would be maybe possible to reutilize again another anti-CD38 monoclonal antibody in combination with whatever standard of care.
All right. Thank you very much. And unfortunately, we don't have time for another question, but I appreciate your great talk and being available for us. I know it's very early in the morning for you, so thank you, and appreciate all your efforts.
Thank you.
If you have questions that we did not get to, feel free to text them to the speakers in the mobile app, and they'll have a chance to respond directly to you. So thank you, Dr. Mateos.
Bye.
All right, next up we have Dr. Orlowski, who leads the myeloma department at MD Anderson Cancer Center and is going to talk to us about management of triple-class refractory multiple myeloma. Dr. Orlowski?
Well, thank you very much for the invitation to speak at this conference, and I'm going to cover treatment of triple-class refractory myeloma with a focus on novel agents that are available and some that are coming, and these are my disclosures. Just to give you an overview, these are the current NCCN guidelines for treatment of relapsed and refractory multiple myeloma. And as you can see, there are more than 30 options. Later in this session, you'll hear talks from Drs. Usmani and Berdeja, and they're going to talk about ADCs, bispecifics, and trispecifics, as well as CAR T cells. So I'm going to try to limit my comments in this presentation to small molecules that are of interest. One of these is a molecule called melflufen, and you probably know that this is a peptide drug conjugate, which is essentially a prodrug of melphalan. Once this drug gets inside cells, aminopeptidases convert it to the active drug, and because these aminopeptidases are expressed at higher levels inside cancer cells, there is a better therapeutic index than there is with melphalan alone. The approval of this drug is based on the so-called Horizon study, and if you look at the bottom right, you can see that 76% of the population on this study overall had disease that was triple-class refractory and had a median number of prior lines of therapy of 5. These are the response data from the publication last year in JCO for the entire population in the middle column, and then the triple class refractory on the right column. You can see an 11% VGPR rate and an 15 to 18% PR rate. Also, some patients with minor responses, and so the overall response rate was about in the 25 to 30% range. But if you include clinical benefit, which means minimal response, then you're talking about 40 to almost 50% of patients responding. And as you can see from this plot, many of these responses were quite durable, with patients able to stay on for 6 to 12 months, and in some cases for an even longer period. Here you can see the progression-free survival data, which was about 4 months for both the overall population and the triple-class refractory population. This is really quite good for a single agent, and the overall survival data showed about a 1-year median overall survival, which hopefully will be improved upon further by combination studies. Toxicities are shown here, and as you can imagine with melphalan, there were hematologic adverse events. In terms of non-hematologic events, there is some nausea and fatigue, but most of these are grade 1 or 2 with few grade 3 or 4 side effects. The one additional note is you probably know that the FDA did halt enrollment to a study looking at melflufen in combination with dexamethasone compared with POM and Dex, but at least as of right now, that does not influence the ability to use this drug as a single agent. And then here are some of the other non-heme adverse events, which again you can see were mostly grade 1 and 2, and infections with pneumonia are something to certainly look for. Another small molecule which we've had for a little bit of time is called selinexor, and this blocks the transport of proteins between the nucleus and the cytoplasm, and in particular it may work by retaining tumor repressor proteins in the nucleus as opposed to them being exported into the cytoplasm, which is in part what cancer cells want to do. We know data from a few years ago about the efficacy of selinexor and dexamethasone. You can see that in the left, the quad and pentarefractory patients had good overall responses. Quad refractory included 2 proteasome inhibitors and 2 immunomodulatory drugs, and penta included patients with anti-CD38. And you can see progression-free survival as well as overall survival data, which are pretty good. And of course, if you combine this with other drugs, for example, bortezomib in earlier lines, you can get an even greater benefit. For those of you that like overall response numbers, you can see here that the overall response rate was about 20% in quad and pentarefractory people, and again up to a 40% clinical benefit response rate in pentarefractory patients. You probably know some of the toxicities, which are usually fairly easy to manage with some experience, and those include thrombocytopenia and anemia and hyponatremia at grade 3 or 4, but most of the others are grade 1 and 2 toxicities. I did want to say one thing briefly about antibody drug conjugates, and this will be covered a little bit by Saad Usmani, but I did want to mention the one that is approved because it is available for triple class refractory myeloma. And this is just an overview showing you that these conjugates work in part by a direct cytotoxic effect, often by having an antimicrotubule agent that interferes with spindle formation and then induces apoptosis. But you can also have them activate something called immunogenic cell death, which brings in the ability for immune effector cells like macrophages, T cells, and DCs to become involved in the immune attack. This was the DREAM2 patient population, and you can see that there were high proportions, almost 100% of patients that were PI refractory, immunomodulatory drug refractory, and anti-CD38 monoclonal antibody refractory. The response rate numbers in different subgroups are shown here, and we're roughly in the 30% range across all of these groups, including patients refractory to bortezomib, to lenalidomide, and to daratumumab. And these are the PFS data with OS actually shown in the blue curves, and now PFS shown here in the red curves. Longer follow-up was just recently published, and you can see that patients who got a partial response or a minor response did much better in terms of PFS on the left as well as OS on the right, compared with patients who had stable disease or progression. You probably know the toxicities of this agent, which include keratopathy as well as thrombocytopenia. And I think everybody is becoming more adept at managing the keratopathy, which involves liberal use of eye drops as well as potentially in the future, different drug doses and different dosing schedules. It also is worth mentioning that there are novel molecules that bind cereblon. The two that are furthest in development are iberdomide and this drug called CC92480, which binds more tightly to cereblon than does lenalidomide or pomalidomide, and therefore gives you a different kinetics of digestion of Aiolos and Icaros downstream. And we have data from a phase 1 study that were presented last year at ASCO that looked at different doses and different schedules. You can see that 50% of patients were triple class refractory in this study, and the response data across a number of different schedules were quite good, ranging from 40% all the way up to 55%. And these responses appear to be independent of prior refractory disease to len or pom, which I think is particularly encouraging. And here you can see again that the durability of these responses in many cases was quite good, some of them being able to get out to cycle 6 or 12 or even further, and many of the responses were still ongoing. In terms of adverse events, cytopenias were most of what was seen at the grade 3 or 4 level. And because neutropenia can be a factor, you do have to watch out for pneumonias. But again, most of the other effects were grade 1 and 2. And this agent, both alone and in dexamethasone, is in an ongoing, potentially registration-enabling study. And then before I conclude, it is worth mentioning that venetoclax, especially for 11-14 translocated patients, is something to consider. We have some older data now from 4 years ago with venetoclax alone and also with dexamethasone, which I'm sure you recall showed good activity in the T11-14 patients. And this is just an overview of what those patients looked like with 5 median prior lines of therapy. And many of them were refractory to proteasome inhibitors and also immunomodulatory drugs. At that time, CD38 refractoriness was less common, and so it was not reported. But the response data, as you remember, showed a 40% response rate for venetoclax with the T11-14 population. And if you look in particular at the bottom parts of this little figure, you'll see that even people that had disease refractory to bortezomib, lenalidomide, carfilzomib, and pomalidomide had a very good overall response rate, especially in that 11-14 population. So the conclusions that I'd leave you with are certainly the relapsed and refractory setting is more challenging to manage because many of the previous novel agents are now being used much earlier. One approach you can take is to take drugs that you've used before and use them in a new combination, and sometimes that can give you good efficacy. But now we have these more novel drugs that you can give to triple class refractory patients either alone or in combinations that definitely have a benefit. And as we learn to use them better and to manage their toxicities better, I think that their efficacy will only improve. So thanks very much. And I put this up just to show our team at MD Anderson and also give you my email address and Twitter account. And I'm always happy to answer questions about your difficult or even not so difficult cases with myeloma. Thanks very much. And again, happy to take any questions as they come up.
That was a great summary of a lot of the approved and in current investigation agents that are out there. We've got about 2 minutes for questions. And one question that I think everybody probably wants to know is, how do you, so let's say a patient is not going to go on a trial. You've got probably 3 agents that are FDA approved now. How do you, or 4, let's say 4, including CARs, how do you make decisions about where you go for a given patient? What's your algorithm?
Yeah, great question. I don't think we have a validated algorithm yet. I hope in the future what we'll have is an immune-based profile that will help us to identify which patients, for example, will respond best to an ADC versus a bispecific versus a CAR T cell, and then drugs like melflufen or potentially selinexor, if you're using them in this setting, could be used more as a bridging therapy, because the data with these immune therapies certainly look better in terms of overall response rate and durability.
Yeah, and are there age things or age parameters that you think about, or PS that might drive a decision one way or the other outside of your immune profiling?
Yeah, great question. I mean, certainly PS is something that's important. And if somebody has a poor PS, then probably moving them in a direction of a CAR T or a bispecific may not be appropriate. And maybe somebody like that should get an ADC, for example, which is at least the easiest in terms of administration with fewer visits back and forth. Whereas if somebody has a good PS, then all of those are options, although one again would have to argue that with the data that we have today, probably either the CAR T or the bispecific would be at the front. Maybe in the future, as the data with belantamab-based combinations come in, it may be that those will be in the top tier as well.
And last one with 15 seconds to go here. How do you think about that question I asked Mari V before about reutilization of DARA or ESA in a patient that's exposed or resistant?
Well, with only 15 seconds, I would say as long as they responded, were not refractory, and tolerated it well, I would have no hesitation at all to reuse DARA. But if they didn't tolerate it or had a short duration of benefit, then it's probably not worth revisiting.
Perfect. Thank you very much, Dr. Orlowski. Great talk and appreciate your time.
Take care.
All right, we're going to move on to the next talk, which is Dr. Saad Usmani, who is the incoming chief of myeloma at Memorial Sloan Kettering. He's going to talk about novel BCMA-targeted ADCs, bispecific and trispecific antibodies. Dr. Usmani?
Hello, my name is Saad Usmani. I'm the chief of plasma cell disorders at the Levine Cancer Institute, and I'm going to be providing an update on antibody-drug conjugates, bispecific antibodies, and trispecific antibodies in multiple myeloma. Here are my disclosures. Just to set up the stage of what we're going to be talking about, these are the various kind of antibodies that we currently utilize in cancer medicine, including multiple myeloma. The naked antibodies can recognize a specific surface marker on cancer cells but have nothing attached to them. The antibody-drug conjugates have a toxin or radioisotope that's attached, and they deliver that toxic payload to the cancer cell, in this case, the myeloma cell. And the bispecific antibodies can recognize the cancer cell, which again, in this case is myeloma cell, but one part of the antibody can recognize either the adaptive or innate immune cell. So it could be a T cell with CD3, it could be NK cell with CD16 or macrophage for that matter. But they try to redirect the immune system cells towards the cancer cell and do the cell kill. And we're going to be primarily talking about the antibody-drug conjugates and the bispecifics, and I will mention the trispecifics as part of this presentation as well. The most exciting target that we've had in myeloma over the past 4 or 5 years that's garnered attention is the B-cell maturation antigen. And there are, the following currently proven investigational approaches that are being looked at. So in the antibody-drug conjugate, we have belantamab mafodotin that's actually FDA approved for 4 or more prior lines of treatment patients. With T-cell activating strategies, we have CAR T-cell therapy, ide-cel, or which used to be called BB2121, that's approved. We're not going to be talking about that. And then we have, bispecific antibodies that are in clinical development but not approved. And we have the most data with teclistamab, and I'll share some of that data in this presentation. But let's start with belantamab mafodotin. It is a BCMA-directed antibody-drug conjugate with a microtubule inhibitor that's attached to it called MMAF. The mechanism of action is for belamaf to identify BCMA expressing cells, and then the antibody drug conjugate is internalized, and within the lysosome, MMAF is released following proteolytic cleavage from the antibody, and the MMAF then leads to intracellular disruption of microtubule networks that leads to cell cycle arrest and apoptosis. Now, belantamab mafodotin has also been shown to induce tumor cell lysis through ADCC and ADCP mechanisms as well, in addition to the toxic payload delivery way of doing it. The trial that led to its approval was the DREAM2 study that was done in patients who had 3 or more prior lines of anti-myeloma therapy, including refractoriness to a PI and IMiD, and the patients had to have progressed on an anti-CD38 monoclonal antibody. But no prior BCM exposure was allowed. Patients were randomized to 2 different doses of belantamab, 2.5 milligram per kilogram given every 3 weeks, and 3.4 milligram per kilogram given every 3 weeks, with the primary endpoint being overall response rate. And over the next few slides, I'm going to talk about the 2.5 milligram per kilogram cohort of 97 patients who were, who had a median of 65 years of age. 42% of them had high-risk cytogenetics, 23% had extramedullary myeloma, and median prior lines of 4 were present in, made up by 84% of the patients. If you look at the prior refractoriness, you can see that this was a fairly refractory population, specifically if you look at the anti-CD38 monoclonal antibody refractoriness. So in terms of overall response rate, responses were seen in 31% of the patients with median duration of response of 11 months, median PFS of 2.8 months, and median OS of 13.7 months. One key adverse event that was identified with this product was eye disorders, which was keratopathy. Keratopathy, I have to explain, is based on slit lamp examination and can happen with or without symptoms. That's why you see the difference between the overall keratopathy in terms of all grade as well as grade 3 or 4 symptoms, or grade 3 or 4 grading, I should say, but with or without symptoms, because you don't see the same degree of visual acuity decrease, blurred vision, or dryness. But in terms of other side effects, you can see that the grade 3 or 4 side effects in other categories like GI, general disorders, procedure-related musculoskeletal, metabolic, or infectious side effects were fairly low. Let's talk a bit more about the keratopathy. It's defined as changes to the corneal epithelium that are observed on ophthalmologic exam. And these were considered area of special interest and were reported in DREAM2 study. And that study actually incorporated an ophthalmology exam every cycle to monitor these in a closer fashion. So let's take a look at the frequency of ocular events. Overall, these keratopathy changes occurred in 72% of the patients. If you look at the symptoms that were seen with this decline were in 56% of the patients, but the changes that actually were worse, 20 by 50 by visual acuity exam, they occurred in 18% of the patients, and discontinuation due to ocular events really occurred in only 3% of the patients. So now belamaf is being evaluated in combination with other therapies and with different dosing as well as with different schedules. And we saw first data around the combination with bortezomib and dexamethasone last year at ASH, and these data were updated at ASCO this year. So 18 patients treated with the 2.5 milligram per kilogram dose along with bortezomib and dexamethasone in patients who had 1 prior line of treatment, and bortezomib refractory patients were allowed. So this, N of 18 included 3 median prior lines of patients. 28% of the patients had high-risk cytogenetics as well as extramedullary disease. And if you look at the overall response rate, it was 78%, VGPR or better rate of 67%, and the responses in prior bortezomib as well as prior daratumumab patients was 75 and 67% respectively. So consistent with the activity of this BCMA ADC that we've seen in earlier lines of treatment. In terms of keratopathy, it was seen in all patients, a grade 3 or higher in 61% of the patients. Blurred vision was seen in 67% of the patients, grade 3 or higher in 28%. No patients permanently discontinued belantamab, and all keratopathy events were manageable with dose reductions and delays. But this will remain somewhat of a challenge for us. And I think there are efforts underway looking at different doses and mitigation strategies as we combine this ADC with other mechanisms of actions. And speaking to that, this is the Algonquin study looking at the pomalidomide dexamethasone combination with belantamab mafodotin. And here you can see that belantamab is being given as a single dose of 1.95 or 2.5 milligram per kilogram or split doses of 2.5 and 3.4 milligram per kilogram every 4 weeks, along with pomalidomide and dexamethasone. So this study was presented at ASH by my colleague Susan Trudell. 37 patients treated, 47% had high-risk disease, 3 median prior lines of treatment. Len refractory patients made up 92% of the patients. 81% of the patients were PI refractory. 43% of the patients were daratumumab refractory. Third of the patients were refractory to lenalidomide, proteasome inhibitors, as well as daratumumab. And here, at a median follow-up of 7.8 months, the median PFS is not reached, and the overall response rate is quite impressive at 88%. If you look at the keratopathy, in the 1.92 milligram per kilogram single dose group, it's seen in 25% of the patients with visual acuity changes in 17%. Median number of patients with dose holds was only 1. Whereas the keratopathy, visual acuity, and the dose holds were higher in the 2.5 milligram per kilogram dose. So, quite impressive results with this combination. And I think this kind of paves the way for ADCs moving forward. Now, switching gears to bispecific antibodies, there are several different constructs, but the idea is the same. The one part of the bispecific antibody recognizes the cancer cell, the other part engages the immune system. And here, for the most part, these are T cell redirecting therapies, but NK cell directing therapies are also coming down the pipe. So teclistamab is farther ahead in terms of its clinical development here. I had presented these data last year, and the paper just got published this year. Teclistamab is a BCMA-directed bispecific antibody. The phase 1 first-in-human study looked at relapsed refractory multiple myeloma patients without any prior BCM exposure. There were initial cohorts with IV formulation that were looked at with dosing of 0.3 to 720 microgram per kilogram along with step-up dosing, whereas subsequently subcutaneous formulation was utilized for 80 to 3,000 microgram per kilogram dosing. And the recommended phase 2 dose is 1,500 microgram per kilogram. So, let's look at the patient characteristics for the subcutaneous cohort overall. 64 years of median age, extramedullary plasmacytomas in 15% of the patients, high-risk cytogenetics in 30%, median of 5 prior lines of treatment. You can see the refractoriness to prior line of treatment in 88% for the whole group. For the recommended phase 2, that all those numbers are quite similar. Looking at the safety, hematologic side effects, all grade as well as grade 3 or 4 were the more common ones in the overall population as well as the recommended phase 2 dose. CRS was seen in 60 and 70% of the patients respectively, but all of them were grade 1 or 2. Neurotoxicity was only seen in one subcutaneous treated patient, and it was a grade 1 event that resolved without intervention. Infections were seen in 51% of the patients. 21% have had grade 3 or 4 infections across all subcutaneous doses, and 23% at the recommended phase 2 dose. In terms of activity for the recommended phase 2 dose, overall response rate was impressive at 65%, CR or better rate at 40%, and VGPR rate of 58%. And this is at a median follow-up of 6.1 months. There were 6 evaluable patients across the recommended phase 2 cohort for MRD negativity, and 5 of them achieved it at 10 to the minus 6, and 1 at 10 to the minus 5, and median duration has not been reached. But there are other bispecific antibodies in this space. Beyond teclistamab, we have AMG 701, which this is a proprietary platform. The formulation is IV, and the highest dose level is showing impressive overall response rate at 83%. We do not have any DOR or PFS data. Similarly, the Regeneron, TeneoBio, and Pfizer bispecifics are showing impressive overall response rate in a similar range. The median prior lines of treatment and refractoriness is fairly similar across the board for these various constructs. And we hope to get more data with these constructs in the coming international congresses. What was more exciting in this space is the development of two novel targets, GPRC5D directed bispecific called telquitamab and FCRH5 directed bispecific called cevostamab. Both of these are showing clinical activity but unique safety features compared to the BCMA-directed strategies. Both of these are earlier in development, and hopefully we'll see a bit more mature data in the coming years. But the fact that we are seeing clinical activity is very encouraging. And then speaking about trispecifics, so the trispecific antibodies are still in preclinical development. With bispecifics, we do not have, in the absence of T cell co-stimulation, the likelihood of energy is there. So here the concept is you're adding a co-stimulatory antigen, which actually increases the T cell's ability to kill myeloma cells. It also suppresses myeloma cell. So preclinical data shows suppression in mouse models, as well as improving proliferation of memory and effector T cells and downregulation of regulatory T cells in primates. So trispecific NK cell engagers are also being developed, which are targeting CD16A on NK cells. So this is quite an active space. If I were to summarize these data, the antibody drug conjugates and bispecifics are representing a new wave of myeloma therapies. They appear to be active. With belantamab, the main side effect that we are dealing with is ocular side effects, and we're trying to figure out the optimal dosing and scheduling. But these side effects appear to be reversible. For bispecific antibodies, it's primarily cytokine release syndrome. ICANS can occur in some patients, but unlike CAR T cell therapies, the percentage is very low. And then low blood counts, which are all treatable. There are several bispecific platforms. In comparison to CAR Ts, the advantage is they're off the shelf, appear to have better safety profile, and some of them already have subcutaneous formulation. And potential disadvantage is the continuous therapy model. BCMA-directed bispecifics are now starting to move into earlier lines of treatment in clinical investigations and being combined with monoclonal antibodies and immunomodulatory drugs. So there's a need to incorporate some of these things into the frontline strategies, and several concepts are in development. And lastly, I think, the GPRC5D and FCRH5 as new targets is very encouraging. And with that, I'd like to end my talk and acknowledge my team here at the Levine Cancer Institute. Thank you for listening to me.
Thank you very much, Dr. Usmani. Great talk summarizing a pretty active area of clinical investigation. We've got a couple questions in the chat for you. The first is regarding CRS monitoring. What would be required in terms of safety profile for you to feel comfortable monitoring a patient for CRS as an outpatient? So what do you need to see to be able to give these bispecifics as outpatients?
So thank you, Sagar. I think, the CRS that we observe with the bispecifics are a bit different from what we observe with CAR T cell therapy. They tend to be grade 1 and 2. And with antibodies like teclistamab, we observe them during the step-up dosing. So they tend to be at a lower dose. They're grade 1 and 2, and you can very quickly manage them with tocilizumab and supportive care measures. I haven't seen a specific signal for hybrid disease, or requirement for any cytoreduction before putting on bispecifics like CAR T cell therapy, for example. So I think it's fairly manageable in the outpatient setting, and this will be the advantage for bispecifics. And that's why I think there'll be more appeal and pick up in the community as these bispecifics become available for us in the clinic.
And in your experience, do you think there's a difference in adverse event profile when they're given IV versus sub-Q?
No, I have not observed that. And, there are some constructs that are sub-Q already, others that are IV. But if you look at that table that I shared with you, the grade of CRS and the percentage of patients who get CRS is fairly similar across the board. There are some constructs that may have some unique features, like the Pfizer one does have this neuropathy signal. That may distinguish it from the others. But I haven't seen the route of administration as being a challenge or determinant of the degree of CRS.
Okay, we got two more quick ones here. To your knowledge, are there ongoing trials combining belamaf with a PI and DEX? And I know you know the answer to this, so I'll let you go. And then we've got one more quick one after that.
So, we've already shared, I actually shared the data with bortezomib and dexamethasone, and that study is ongoing. And there are other cohorts being added with carfilzomib as well. And there are certain IITs evaluating in earlier lines of treatment.
Okay. Last question is, where do you believe the GPRC5D and FCRH5 targeting agents need to be used?
That's an open question. I think we need to ask the question whether we can use them before BCMA or after BCMA. I think we just need more safety data and activity data with long-term safety concerns with some of the early signals with dysgeusia we've seen with some of the GPRC5D targeting therapies. Once we do, I think it's still an open question. I don't see a reason why we can't do it either way. GPRC first and BCMA later, or vice versa, or potentially even combine both.
Thank you very much. Great talk, and appreciate your taking time to do questions. I know you're in Vienna as well, so get some rest. All right, so next up, we're going to go to Dr. Jesus Verdeja, who's going to talk about BCMA-directed CAR T cells, early results, and future directions. Dr. Verdeja is from the Sarah Cannon Cancer Institute in Nashville, Tennessee, and leads their myeloma program there. Jesus?
I would like to thank the SOHO organizers for inviting me to discuss what I consider to be one of the most exciting topics in myeloma. The title of my talk is BCMA-directed CAR T cells, early results and future directions. These are my disclosures. The first half of my talk will concentrate on the two lead compounds, which are idacaptogen viclucel or ide-cel and ciltacabtagene autoleucel. I will then follow with future directions of these products, as well as new products that are looking to improve on these results. First, we'll start with ide-cel. The phase 2 KARMA trial was recently published in the New England Journal of Medicine and updated at ASCO 2021. I'll remind you that ide-cel is an autologous CAR T cell product that uses an anti-BCMA single chain variable fragment for its tumor binding domain, 4-1BB and CD3 zeta signaling domains. Patients for this trial were relapsed refractory and had at least 3 prior lines of therapy and previous exposures to IMiD, proteasome inhibitors, and anti-CD38 antibodies. Primary endpoint was overall response rate. As you can see on the right, 158 patients were screened, 140 leukapheresed, and 128 patients treated, 4 at 150, 70 at 300, 54 at 450 million CAR T cells. The baseline demographics show that these were high-risk patients, with 35% having high-risk cytogenetics, 51% having high tumor burden, and 39% extramedullary disease. On the right, you see that patients were heavily pretreated with 6 prior lines of therapy. 84% were triple refractory, 94% had anti-CD38 monoclonal antibody and were refractory. This is the best overall response. On the right-hand side, you see that for the entire population, the overall response rate was 73%, with 33% complete response rates. If you look at the graphs to the left, you see that by dose level, it appeared that responses improved with dose level, with the 450 million cell cohort having overall response rate of 82% and 39% complete response. Similarly, in survival, with a median follow-up of 24.8 months, we learned that the median progression-free survival was 8.6 months, and the median overall survival was an outstanding 24.8 months. If you look at the graphs themselves, the curves, you see that on the left, you see the PFS by target dose, and the PFS appears to be dose-dependent, with the median PFS of 12 months at 450 million CAR T cells, and on the right, you see that the PFS appears to improve with depth of response, with median PFS of 20 months in patients achieving CR or SCR. The side effect profile was what we come to expect with CAR T cells. You see the cytopenias are quite prevalent, including grade 3 and 4 cytopenias. Cytokine release and neurotoxicity, of course, are the what we've now come to expect with CAR T therapy. You can see the cytokine release syndrome was seen in 84% of patients, but the majority were grade 1 and 2, with only 5% of patients having grade 3 or higher. The time to onset to CRS was just 1 day, which would be important in comparison to cilta-cel, which you'll hear about in a bit. Neurotoxicity was rare, only seen in 18% of patients, and only 3% of patients having grade 3 or higher neurotoxicity. Median onset of 2 days, mean duration of 3 days. Jumping now to the CARTITUDE-1 study, which is the phase 1b/2 study of cilta-cel in relapsed refractory myeloma. You see the cartoon of cilta-cel, which differentiates itself from ide-cel in that it has 2 BCMA targeting single-chain antibodies designed to confer avidity with, again, a 4-1BB and CD3 zeta signaling domains. Similar eligibility criteria as the KARMA study, with the phase 1b objective being characterization of the safety and confirmation of the recommended phase 2 dose, and the phase 2 to evaluate the efficacy of cilta-cel. 113 patients were enrolled, 101 were underwent lymphodepletion, and 97 patients were actually dosed. Patients were treated with a target dose of 0.75 times 10 to the 6 CAR viable T cells per kilogram in the phase 1b, and this was the dose that was chosen for the phase 2. Thus, all patients received the same dose. And as you can see, the median administered dose was 0.71 times 10 to the 6 CAR viable T cells per kilogram for all patients. And thus, all patients from the phase 1b and phase 2 were evaluated together. Baseline demographics, again, high-risk genetics in 24% of patients, and 20% of patients had plasmacytomas. On the right, you see these were heavily pretreated patients with 6 prior lines of therapy. 88% were triple refractory, 99% were refractory to anti-CD38 monoclonal antibodies. On the left, you see the overall response rate, which was quite impressive at 98%, with stringent complete response of 80.4%. On the right, you see that the median progression-free survival and overall survival have not been reached. The 18-month PFS was 66%, and the 18-month overall survival was 81%. In terms of toxicity, again, cytopenias were prevalent, including grade 3-4 cytopenias. Here we do see a few more elevations in AST and ALT compared to ide-cel, although these were self-limited. The cytokine release syndrome was very common, seen in 95% of patients, but only 5 patients with grade 3 or higher. But what's really intriguing here is that the time to onset of the CRS was 7 days in comparison to ide-cel, which is just 1 day. Neurotoxicity as a whole was seen in 20% of patients, with 10% of patients having grade 3 or higher neurotoxicity. But traditional ICANS was seen in 60% of patients and 2% grade 3 or higher, with the median onset of 8 days, which is around the time when you expect the CRS as well. In this case, there were 12% of patients that had this other neurotoxicity, which actually had an onset much later, median time of 27 days, with 9% of these patients being grade 3 or higher. These other neurotoxicities were more like movement disorders and Parkinsonian type symptoms, as well as focal cranial nerve findings. And so when we look at the patients that develop this sort of later neurotoxicity or other neurotoxicity, it appeared that these patients all shared some risk factors. And so the risk factors that we identified were patients who had higher tumor burden, patients who developed grade 2 or higher CRS, patients that did develop prior ICANS, and patients that had high CAR T cell expansion and persistence appeared to be at risk for developing these late neurotoxicities. And the certain mitigation strategies were implemented that included enhancement of the bridging therapy to try to reduce tumor burden prior to CAR T infusion, early and aggressive recognition and treatment of CRS and ICANS, as well as this handwriting assessment, which appeared to predict for development of late neurotoxicity. Once these were implemented, over 100 patients have been treated in the CAR-T programs, and no other late neurotoxicities have been observed. Perhaps these neurotoxicities can, in fact, be mitigated. So what is the future for these two? As you all know, ide-cel was FDA approved in March of 2021, with the indication being for relapsed refractory multiple myeloma with at least 4 prior lines of therapy and prior PI, IMiD, and anti-CD38 monoclonal antibody treatments. Cilta-cel submitted its BLA, and the PDUFA date is expected November 29, 2021, and we hope that this will be approved by the end of this year, early next year. If it works in the relapsed refractory setting, perhaps it will work better earlier on, and so this is being tested with both ide-cel and cilta-cel. You can see various KarMMa and CARTITUDE trials and earlier phases of the disease, including frontline with KarMMa-4, looking at ide-cel in patients with high-risk multiple myeloma who are newly diagnosed, and CARTITUDE-5, which is a randomized trial of cilta-cel versus VRd newly diagnosed transplant-eligible patients. So we await these results to see if we can improve on these spectacular results that I showed you to date. Unfortunately, patients still relapse with both of these products, and so we have a long ways to go before we think we've maximized the benefit of these therapies. And so here, I know this is a busy slide, but I just wrote down some of the potential things that can be done to improve on the current products. We know that downregulation and loss of antigen expression can occur. BCMA negative relapses have been reported, and so perhaps the use of gamma secretase inhibitor, which can augment expression of BCMA, may be helpful. Perhaps dual targeting of CAR T cells will help obviate this problem as well. We know that resistance develops, and although we don't understand the exact resistance mechanisms, we know that there are mechanisms both within the tumor cell and the tumor microenvironment, and perhaps rational combinations within the checkpoint inhibitors, monoclonal antibodies, and others may be important, and these are also ongoing. The quality of the CAR T and the loss of the CAR T appears to be important. We know that there is development of anti-CAR antibodies, and the retreatment with ide-cel or cilta-cel does not appear to be beneficial, although the data is scant at this time. Perhaps the fully human constructs will be able to obviate this problem. There is a potential that the actual phenotype of the T cells may be important, effector phenotype versus memory stem cells, and thus BB21217, for example, and others are looking at enriching for the memory stem cell phenotype in hopes of having more prolonged control of the disease. Of course, looking at alternate antigens, as you've heard with the bispecific antibodies, is also occurring with CAR T cells, so going beyond BCMA, and off-the-shelf CAR Ts. So the autologous products can be a little cumbersome. There's a delay of almost a month before the actual leukapheresis to the infusion of the stem of the CAR T cells, and thus perhaps the allogeneic CAR T cells will make a significant inroads in here, and we have some early results from this. Here I'm actually as a table of some of the products that are examples of trying to overcome some of the deficits of the early CAR Ts. We heard at this year's ASH from CT053, which is the LumaCAR2 trial. This is a fully humanized BCMA CAR T, which in theory would decrease potential for anti-CAR antibodies in hopes of having longer lasting CAR Ts, but also the potential for retreatment. And as you can see, only 20 patients reported, but impressive overall response rate of 94%, reasonable toxicity. So we await further results from the study. BB21217 is basically BB2121, which is ide-cel, which is cultured with PI3 kinase inhibitor, in theory enriching for memory-like phenotype of the CAR T product. And in this case, we've seen some early data with 69 patients treated at 150 to 450 million CAR T cells with an overall response rate of 68%, CR rates of 29%, similar toxicities, but of course here the important thing will be waiting for the progression-free survival and the durability of these responses. PBCMA 101 is actually a very different type of CAR T. It uses centaurin instead of a single-chain variable fragment, which is fully humanized, presumably will also decrease anti-CAR antibody production. It also is the first non-viral, uses the first non-viral transduction of the CAR using a piggyback transposon. and also has a safety switch. And again, we've seen some early data with 55 patients treated. And if you look down to the CRS and neurotoxicity is incredibly well tolerated, but we don't have very much in terms of its efficacy. We do have an overall response rate of 57%, but we don't know the depth of response and durability, and thus further data is greatly anticipated. And finally, on this slide, you see that there's dual targeting of CAR Ts now being presented with the dual BCMA CD19 fast CAR T platform CAR T presented at ASH as well and at ASCO. Again, with 16 patients only, but very impressive overall response rate, 94%, all complete remissions and well tolerated. And thus we await maturing of those results. But without a doubt, I think the most novel thing presented at this year's ASH was the universal data of the phase 1 ALLO-715 BCMA CAR T, which is the first allogeneic BCMA-directed CAR T cell in myeloma. Here you see they use a human anti-BCMA single-chain variable fragment along with the 4-1BB and CD3 zeta signaling domain. What's different here, of course, is these are allogeneic T cells, and thus they use TALEN technology to knock out the T cell receptor, which in theory eliminates the expression and minimizes risk for graft versus host disease. They also use the same technology to knock out CD52, and they use ALLO-647, which is their anti-CD52 antibody, as part of the lymphodepletion to prevent graft rejection. So these patients, again, relapsed refractory, 3 prior lines of therapy. Patients undergo lymphodepletion and receive the ALLO-715 infusion. And as you can see here on the table at the bottom right-hand corner, you see the lymphodepletion is a little bit different from what we're used to. Fludarabine, cyclophosphamide, same dosing as expected, but also now incorporation of the ALLO-647, which is our anti-CD52 antibody. And so the initial results were very intriguing. Again, this is the first allogeneic BCMA CAR T cell. 90% of patients were treated with 5 days of study enrollment. Compare that to the autologous CAR Ts that patients get enrolled and usually don't get their CAR Ts for a month or more. So that's actually a significant improvement in my mind. There was no bridging therapy that was required or allowed for ALLO-715 dosing, which again is also a significant advantage. 31 patients have been treated with relapsed refractory myeloma, median 5 lines of prior therapies with doses of 40 to 480 CAR T cells. Safety looks impressive with cytokine release of 45% with no grade 3 or higher CRS, no ICANS, and no graft versus host disease reported. One of the things we're concerned about with the use of the anti-CD52 antibody, of course, is infections. And thus far, they have not seen any infections outside of the expected infections we're seeing with the autologous products. The results are thus far impressive with their dose level 3 of 320 million CAR T cells of overall response rate of 60%, and 5 of the 6 VGPR patients achieving MRD negativity. Thus, in conclusion, I think CAR T therapy is here to stay in myeloma, and we now have FDA-approved CAR T therapy, at least 1, possibly 2, in the near future. The results are very impressive, but unfortunately relapses still occurs, so we still have much work that is needed to best understand how to best use this therapy. Should we be using a single agent in combination? Do we need maintenance? Do we not? All those questions are being addressed in clinical trials. But I think, as you've heard, we have ADCs and bispecifics, all to the same target. And so understanding the rational sequencing of the available BCMA therapies will also become very important. But I think without a doubt, the future looks bright. And with that, I will stop, and I thank you for your attention.
On a really exciting, rapidly moving area in myeloma therapy. We've got about 1 minute 50 seconds, so I'm going to rapid fire 2 quick questions to you. The first is, do you see the timing of the appearance of CRS between ide-cel early and cilta-cel late to be important? If it is, why? If it's not, why not?
I think that's a great question. I think it brings up an important point that each CAR T product is going to be specific and have certain nuances that will kind of, I think, help direct your therapy. But I think there's pluses and minuses to both. So with ide-cel, we know what to expect. So the expectation is you're going to get CRS in the majority of patients. usually within a day of the infusion. And so for the most part, most patients will probably be admitted to the hospital. You can kind of see them over the next 3 days. And if they do well and they overcome their toxicity, they could probably be discharged. On the other hand, treating as an outpatient completely, I think it may be difficult until we figure out sort of algorithms on how to do that safely. With cilta-cel, on the other hand, I think because of the CRS happening around day 7, you're more likely to be able to potentially infuse as an outpatient and then only admit those patients that have toxicity or plan for a delayed admission following the infusion. So the plus is it can be done as an outpatient. The minus perhaps is you may have a little more sort of kind of trying to figure out when to admit the patient.
Okay, so one other question. So another one came in, so we've got 2 more for you. Myelosuppression associated with CAR T, is that an issue that's underappreciated? And you may want to compare and contrast with CD19, where I think myelosuppression is a much bigger deal.
Yeah, no, I think it is, I think, an underappreciated toxicity. Definitely both products, if you look at the acute toxicity, have significant cytopenias, grade 3, 4, in the majority of patients. I think ide-cel actually has a little bit of a longer sort of recovery phase, and I'm not sure exactly why that is. I think the cilta-cel, we've seen a recovery that may be a little bit earlier, but nonetheless, we're talking about a month potentially of these cytopenias, and I think it is important to realize that, and that patients often will require growth factor support and potentially transfusions over the next 4 weeks. So so it's not all about CRS and neurotoxicity, although that's what we concentrate the most. And along with the cytopenias, obviously come the potential for infections. So I think as we're learning more about the different products, I think the long-term management of these patients and the protection and sort of the infectious prophylaxis is going to be very important for these patients in the long run. And that's areas that are being investigated, and hopefully we'll have better guidelines for people.
And the last one, which give me a quick 10-second answer. The allo CAR T cells doesn't have the risk of GVH as a traditional allo transplant would have, right?
Correct.
Yeah. Okay. All right. Thank you so much, Jesus. Great talk, and appreciate your being here for SOHO.
Thank you.
All right. Next, we're going to get up to the oral abstract. This was the highest rated abstract in the myeloma session. This is MM119, updated results of cilta-cel, a B-cell maturation antigen directed chimeric T-cell, chimeric antigen receptor T-cell therapy in relapsed refractory multiple myeloma. This will be presented by Dr. Saad Usmani, formerly or soon to be formerly of Levine, about to be at Memorial. So thank you. Let's go ahead and start, Saad.
Hello, my name is Saad Usmani. I'm the Chief of Plasma Cell Disorders, and I'm going to be presenting the abstract titled Updated Results of Cilta-Captogene Autoleucel, or cilta-cel, a B-cell maturation antigen-directed chimeric antigen receptor T-cell therapy in relapsed refractory multiple myeloma on behalf of the CARTITUDE-1 investigators. Just to remind everyone, CARTITUDE-1 is a phase 1b/2 study evaluating cilta-cel, which is a CAR T-cell therapy with 2 BCMA targeting single domain antibodies in patients with relapsed refractory multiple myeloma who have been heavily pretreated. Previously at ASH last year, my colleague, Dr. Deepu Madhuri, had presented the 12-month follow-up of cilta-cel's activity in this patient population, showing an overall response rate of 97%, a stringent CR rate of 67%, and overall 12-month PFS and OS rates of 77 and 89% respectively. And here I'm updating these data with a median follow-up of 18 months. The primary objectives of the phase 1b portion of the trial was to characterize cilta-cel safety and confirm the recommended phase 2 dose, whereas that of the phase 2 portion was to evaluate the cilta-cel efficacy. The key eligibility criteria are progressive multiple myeloma. Patients had to have 3 or more prior lines of treatment or double refractory status. They had to have prior PI, IMiD, and anti-CD38 therapy. They had to have measurable disease by IMWG criteria and ECOG performance status of 0 to 1. The screening period was 28 days before patients went on to receive apheresis. And if needed, depending on disease burden, they would get bridging therapy before starting lymphodepleting chemotherapy with fludarabine and cytoxan, and then go on to receive the cilta-cel infusion. At a median of 0.71 million CAR-positive viable T cells per kilogram body weight dose was delivered, and then patients were followed for post-infusion assessments, which included safety, efficacy, PK, PD, and biomarkers. In all, 113 patients were enrolled and apheresed, 101 went on to receive lymphodepleting chemotherapy, and 97 received cilta-cel infusion, 29 in phase 1b, and 68 patients in phase 2. And there are 23 patients who are still being followed on the phase 1b portion and 53 on the phase 2. A total of 73 patients received bridging therapy. The median turnaround time for cilta-cel was 29 days, and no patients discontinued due to manufacturing failure. And one patient did receive retreatment with cilta-cel. These are the baseline characteristics, which remain unchanged from the ASH presentation. Just to highlight, median age of 61 years. African American patients made up 17.5% of the population, extramedullary myeloma in 13.4% of the patients, and high-risk cytogenetics were there in 23.7% of the patients. Median of 6 prior lines of treatment, triple class and pentadrug refractory patients made up 87.6 and 42.3% of the population, and almost all the patients were refractory to last line of treatment. That's 96 of the 97 patients. The overall response rates continue to deepen over time, 98% overall response rate, an impressive stringent CR rate of 80.4%, and VGPR or better rate of 94.8%. The median time to best response as well as that to CR or better was 2.6 months. Median duration of response is 21.8 months for the whole population, and that for the stringent CR has not been reached. And the response rates were comparable across various subgroups, including prior lines of treatment, refractoriness status to various therapies, extramedullary plasmacytomas, or cytogenetics. Looking at MRD negativity in evaluable patients, which were 61 in all, 92% of the patients had MRD negativity at 10 to the minus 5 using NGS. If we looked at all 97 patients, that percentage was 57.7%. At a median follow-up of 18 months, the 18-month PFS for all patients was 66%, 18-month OS rate was 80.9%. The median, or rather 18-month PFS percentage for stringent CR patients was 75.9%. So quite impressive results in all. From a safety perspective, at the 18-month follow-up, no new safety signals have been observed. The grade 3 or 4 more common AEs were hematologic in nature, as you can see on the left side of this slide. In terms of CRS, almost all patients, 92 of the 97 had CRS with a median onset of 7 days and median duration of 4. And of the 92 patients, 91 had resolution of CRS within 14 days of onset. Neurotoxicity occurred in 20.6% of the patients, with grade 3 or higher being in 10.3%. ICANS was in 16.5% of the patients, with grade 3 or higher being in 2.1%, and other neurotoxicities occurred in 12.4% of the patients, with grade 3 or higher being in 9.3%. But no new incidents of neurotoxicity or movement and neurocognitive TEAEs were observed. Looking at those 5 patients specifically that had the movement and neurocognitive TEAEs, the following risk factors were identified. They had 2 or more of the following factors: either high tumor burden, grade 2 or higher CRS, ICANS, high CAR T cell expansion and persistence. And based on these findings, in the subsequent CARTITUDE program, enhanced bridging to reduce tumor burden, early and aggressive treatment of CRS and ICANS, and handwriting assessments and extended monitoring were introduced, which led to reduction and prevention of these AEs subsequently. So in summary, at a longer follow-up of 18 months, a single dose of cilta-cel led to early, deep, and durable response in heavily pretreated patients with multiple myeloma. overall response rate of 98%, stringent CR 80%, MRD negativity at 10 to the minus 5 using NGS was 92% in evaluable patients. The 18-month PFS and OS rates were 66 and 81%. Cilta-cel is showing a safety profile that's consistent with its mechanism of action without any new safety signals. And I've already highlighted the new mitigation strategies, patient management strategies that are helping prevent and reduce the incidence of neurotoxicity in the overall CARTITUDE program based on the experience in CARTITUDE-1. And Cilta-cel is now being investigated in ongoing phase 2 CARTITUDE-2 study and phase 3 CARTITUDE-4 study in earlier lines of treatment. Thank you so much for listening to me.
I believe that Dr. Usmani had to drop off the Zoom here, but if there are questions for him regarding this abstract, please feel free to contact him through the app. As for other questions, feel free to directly contact our faculty in order to make sure that we stay on time. As you know, there's a very tight agenda, so we've got a lot of information. So hope you all enjoyed, I think, what was just an absolutely fabulous session with lots of great information from really good speakers who are in the clinic every day giving you information about what they're doing. And have a good evening, and we'll see you tomorrow at Soho.